Well, good morning, everybody. I am the first speaker, so hopefully you have your wake-up morning drink of choice, whether it's coffee, tea, or a mimosa, here or virtually. I know how hard it is to put on these conferences. I'm actually now, that bio is a little outdated, I'm now the vice president of our California Association, so we're working diligently on our next conference. So a huge thank you to everybody involved in putting this on. It is a tremendous effort. Really tremendous effort. I think you must live in one of the most beautiful places in the world. We do not get this sort of fall in San Diego, and I went for a walk yesterday and was just blown away with the natural beauty. So to be here for me is, I'm grateful for the opportunity, and it's an honor to share what I've learned and to be able to use my book also as a fundraiser for your association to try and promote and advance what is all of our cause, which is naturopathic medicine. We're going to have time for questions afterwards, so please hold them until the end, unless you're really excited, and then interrupt me. That'd be great. I'm going to try and keep it really upbeat because I know it's early in the morning, so everyone's got to wake up. Here are my disclosures. I own a dietary supplement company, MBI. We do have products for bone health. So there are hundreds of citations in this presentation, even more in the book. So what I'm going to tell you is all correct and accurate. However, do your own homework also. Really encourage people. I love when people become passionate and dive into a subject, as I did over 15 years ago when it came to osteoporosis. This was never something that I ever planned on specializing in bone health, but I started getting patients as Dr. Bill Mitchell, I was fortunate enough to have him as a teacher before he passed, said in our advanced therapeutics class, when a student asked him, should we specialize, he wisely said, your patients will come to you. They will tell you what they need. And if you listen well enough, you will hear it. And I took that to heart. I started getting some osteoporosis patients, and I thought I was doing a great job. And then my mother-in-law, who had osteoporosis and still does, and was taking Fosamax, fell and broke her hip. And I said, wait a minute. Her bone density was going up. Her doctors were happy. She was happy. I had been happy. What went wrong? So I started really looking at the research and digging in, going down that rabbit hole, and here I am 15 years later with the opportunity to speak in front of you. I do own, the book is self-published. I do get profits from that. Live Flout Media is our publishing company that I own with my wife, and everything else, as was already said. So this is the overview, and that's all I'm going to say about that. So basically, we're looking at a disease that has an outdated diagnostic definition. The diagnostic definition is based on a T-score, but the definition of the disease itself really revolves around a skeletal disorder with compromised strength predisposing to increased risk of fractures. And if you get nothing out of this talk at all today, I want you to take one thing back to your clinics and one thing back to your patients. There is only one important question when it comes to osteoporosis. The only one. Am I going to break a bone? What is my fracture risk? How well does test X, test Y, treatment X, treatment Y, how well does it either predict a fracture, or has it been shown, if it's an intervention, to reduce fractures? And I'm going to keep going back to that over and over. 80% of osteoporosis occurs in women. The majority of cases are postmenopausal women. Everybody in this room knows that already. But did you know that 30% of postmenopausal osteoporosis cases are caused by things other than the drop in estrogen? Raise your hand if that's new information today. Phenomenal. Not to everybody. I'm glad some people knew that. And we'll talk about what a little bit later, what I think is the most common cause for many. Secondary osteoporosis, obviously, caused by other issues, medication-induced osteoporosis or comorbidities. Huge prevalence. It's going to be going up. We really are looking at a tsunami of cases as the demographics are not in our favor. The population is getting older. It primarily is a condition, as everybody in this room knows, that affects people as they get older. And I just heard a few weeks ago, an amazing fact. There are more people in this world now over the age of 65 than younger than 5 years old. That blew my mind. That's here in the US, that's around the world. So we are really looking at a tremendous wave of new cases that are coming to all of us, to all of you, and all of you online. There you are. I talked about 80% women, 20% men. Huge cost, billions of dollars, tens of billions of dollars. There's the wave I was talking about. You can just see that big hump kind of going to be growing. So the real risk, as I mentioned, were fractures. Every 30 seconds, someone with osteoporosis breaks a bone. And oftentimes, chronic pain, especially in the elderly, can be caused by fractures, lead to further disability. And if you are 50 years and older, and this is for white women, there's a 40% chance that you're going to have a fragility fracture, and for men it's 13%. However, the risk of dying if you're a man is almost double what it is for women. Authors have speculated, researchers have speculated as why that's the case, and it's thought that the comorbidities in men as they get older are more severe than they are in women. And that predisposes people to that downward spiral that starts to happen when they fracture a hip. The greatest risk is with a hip fracture. Women who break a hip who have osteoporosis are up to 36%. There's up to a 36% chance that they're going to be dead within a year. Those who survive, over half of them will never regain their pre-fracture level of mobility and lifestyle, and the pain will be chronic. The mortality risk for hip fracture is actually greater than breast cancer. When you take all the SEER stages combined, the 5-year mortality from breast cancer is about 10%, and you've got up to 36% chance of dying from a hip fracture, as I mentioned. Greatest risk of dying is in the first 90 days, so if they survive that, that's fantastic. Sort of goes down from there, but there are still years later some downstream effects that will plague most people. And as I mentioned, for hip fractures, the mortality risk is almost double in men. Citations. So let's talk about morbidity. I talked about never returning to full function. Well, 20% of people will actually need nursing home care, and up to 60% do not regain their pre-fracture level of mobility. So they may need help with activities of daily living, shopping, cooking, cleaning, moving around, all that stuff. And after those who survived after 1 year, 27% didn't even regain full independent mobility. So it's not just about the individual patient. This is really a story about families, extended family, and communities. Because the effects that this has is I think of it similar to Alzheimer's disease, where you have these caretakers that end up being primarily family members, and how it impacts their life and their family lives and their communities' lives. And this is a similar situation. So let's compare it with other diseases. When I learned this, it blew my mind, because I just recently, in writing the book, discovered this information. So the combined lifetime risk for fracture is equivalent to cardiovascular disease. In women over 45 years old, osteoporosis causes more days in the hospital than heart attacks and breast cancer. And the adjusted impact of disability-adjusted life years is greater than for hypertension, breast cancer, rheumatoid arthritis, stomach cancer, prostate cancer, ovarian cancer, and Parkinson's disease. And a woman's risk of an osteoporosis fracture is equal to her combined risk of breast, ovarian, and uterine cancer. And yes, there's an Osteoporosis Awareness Month once a year. But you don't have people wearing these pink ribbons around or posting on social media fundraisers typically for osteoporosis. Just as it is a silent disease, there are no symptoms until suddenly somebody just breaks a bone. That oftentimes is the first symptom that indicates there's a problem, and then they go for a bone scan. By the way, anyone 50 years or older who breaks a bone should get a DEXA scan. Just as it is a silent disease, it is something that is permeating healthcare, it's permeating practices, and it's permeating people's lives and families' lives, and I hope that with my work I can raise more awareness of this issue and provide solutions, which is what I'm going to be getting to. Most, 73% of fractures are non-vertebral fractures. That's important because when you start digging into the research and the literature on the medications, the FDA-approved medications, they mostly report vertebral fracture risk reduction because they're not very effective or as effective at hip fractures. And then if you really try and parse the data and you say, well, wait a minute, what about primary versus secondary fractures? Well, then the story gets even murkier because they tend not to define that well, and for good reasons. All but one osteoporosis, only one osteoporosis medication has been shown to be effective at reducing both vertebral and non-vertebral primary fractures, and it's Zometa. So everybody's being given Prolia and Fosamax and Actonel, and they've never had a fracture before. It doesn't prevent fractures if you've never had one. And also why this is important, because there's an assumption out there that a bone is a bone is a bone. Well, because of vectors of force and physics, that's not true. There's a lot more force being put on your hips than your spine as people bend and move. And so 73% of fractures are non-vertebral fractures. Remember that, because when you look at the data, it's important to understand what you're reading and how it relates to the clinical endpoint, which is breaking a bone. So if somebody breaks a fracture, breaks a hip, what are predictors of that will elevate their risk of dying? Well, being older, being a male, poor functional status. In general, the number one predictor of a fracture is poor gait and instability. All right? So everybody in this room, I'm sure, your clinical encounter begins the moment you see a patient. I hope that also includes just watching how steady they are on their feet, because that is the number one predictor of fracture. And poor functional status is a predictor of mortality as well. Osteosarcopenia. So the combination of low bone mineral density and low muscle mass is deadly. There is a 1.8 times higher mortality rate than non-osteosarcopenic patients, but interestingly, and I don't know why this is the case, the increase in mortality was only in men, not in women, in this study. There's only one study, I believe, that's looked at this so far. But in men, that's a big issue. Every 5 years of advancing age, there's a 30% increase in risk of mortality. If you break a hip, mortality risk is elevated for 10 years after, according to this study. You want to watch that. It's not that it goes away a year later, they're doing better. You want to make sure that they understand this is a long-term issue. So in community-dwelling adults, as I mentioned, it's risk for falls, risk for fractures, the gait or balance abnormalities. There's a star next to it, so you know. But hopefully you're evaluating footwear. Hopefully you're evaluating also, just sensory deficits, because if they have a hard time tactically feeling, maybe their gait's off because of that. Maybe they have paresthesias that they're dealing with. If they're doing alcohol or drugs, there's a list here, which are also, hopefully things you're already kind of looking at and evaluating. But if you're doing an osteoporosis specific intake, you do want to look at all of these things. And I'm going to talk a little bit about medications. Yes. Oh, so excited. You had to ask a question. I love it.
Yeah, I need to add little dog ownership.
So environmental hazards is a real issue. When you talk about fracture-proofing your home, and there's a whole chapter in my book about that. And I did not mention dogs. Maybe in the next issue I will. Thank you. But anything that people can trip over. Throw rugs are deadly. That's how my mother-in-law broke her hip. She shuffles. So elderly sometimes, and people in general, if they're shufflers, but she caught her foot on a throw rug, and that's how she took a fall. But environmental, most accidents are going to occur in people's homes. So making sure that corridors where they walk most are well lit. You can get lights that are motion sensor that light up at night for the pathway to the bathroom. Throw rugs are out of the house. Any obstacles, a corner of a table that's jutting out in the middle of a walkway is moved back or removed. Loose steps are fixed. Handrails are fixed, or handrails in bathrooms. Those things are really, really important when you're looking and taking a holistic approach. Oh, I'm hitting the wrong one. I'm hitting the laser. Hope I didn't blind somebody. Okay, so does anybody here know how well a bone density test predicts fractures? Raise your hand if you can give me a percentage in men and women. It's the gold standard. That is the diagnostic requirement for osteoporosis. You have to get a bone scan, a central bone scan, and you get a diagnosis and everybody's freaked out. So in the literature, if you start looking, most of the time you're going to see relative risk. Well, relative risk isn't not what we want. We want absolute risk, right? Not how much am I going to break a bone relative to somebody else, but with low bone density. But am I going to break a bone relative to everybody else, relative to the population? Well, a bone density test, and this is data from the 1990s, only predicts 44% of women who will break a bone and only 21% of men. Every organization that's looked at this data, every published position statement that's out there, correctly has concluded that fracture risk depends on factors largely other than bone density. And yet, from a conventional approach, talking about a patient's bone density and how to improve bone density is almost exclusively what's focused on. And like I mentioned with my mother-in-law, so the patient's happy, the doctor's happy, they're treating a number on a test, they're not treating the person in front of them, they're looking at a surrogate marker that is a poor predictor of fracture, and the person is not safe. And then they're prescribing medications that actually haven't even been shown to prevent a primary fracture. Why doesn't a bone density test do a better job at predicting fractures? Well, because bone is not just minerals. A bone density test only measures the mineral content of bone. Minerals give bone its hardness, but it's the extracellular matrix in bone that gives bone its quality and its ultimate strength. The collagen in bone, healthy collagen, is flexible. It's like rebar in a building. That's what gives it its ultimate strength, and that's what the minerals bind to. 90% of collagen in bone is type 1 collagen, but there are also about 200 non-collagenous proteins in bones, which is why when people say, well, I'm just going to run an osteocalcin test, or I'm going to run this other test that measures one protein, and they think they're protecting their patients, they're doing the same, they're making the same mistake that the conventional doctor or anybody who's just looking at bone density scores is making as well. And in fact, osteocalcin is not a great indicator for fracture risk. And that's can be another talk as well. I'm happy to speak to people about that. Actually, in the Natural Medicine Journal, there's a whole article, two series articles I wrote on. One is on osteoporosis testing. There's a section on osteocalcin in there, so if you go and find that on the Natural Medicine Journal website, you can read the data on that, and NTX and CTX and DEXA scans and CT scans and ultrasounds and all of that on there. And then there's a whole other article in there on medication-induced osteoporosis on their website. So you've got to really also look at the bone as a tissue, a regenerative structure. And what we can do is provide the environment both with diet and lifestyle and nutrients and dietary supplements for that tissue to heal, for it to become stronger. Osteoporosis can absolutely, and when I'm talking about osteoporosis, I'm talking about that bone density because that's a diagnostic criteria. Osteoporosis, bone density can definitely improve using natural methods, which everybody in here knows, but more importantly, fracture risk can be reduced as well. Which one? So I talked about this. So there's a citation from 2008. Oh, I said from the 1990s. From the 1990s, we've known that a DEXA scan predicts less than half of fractures. This 2008 article went into a little more detail with the actual percentages. So what does fracture risk depend on? Well, according to North American Menopause Society, getting older, yes, low bone mineral density is one variable. And I like to, when I get a patient who comes in, they're always scared and they're focused on their bone density test. So I like to tell them the statistic about it only predicts 44% of women and 21% of men who will get a fracture, and that your fracture risk depends on other things, mostly upon other things. And that's only one little piece of the puzzle to calm them down, to help them be able to think and reorient and get them involved in wanting to do more and take more ownership for their health. So that, if you also want to remember something else from my talk, that's a good one just in terms of communicating with patients and talking to them to frame the discussion within the larger context. History of fracture, I believe there's up to about a 30% risk of a fracture within 5 years if you've had a previous one. History of fracture in a parent, being underweight, smoking. How am I doing on time? Low calcium or vitamin D intake, alcohol, impaired vision. You can read all this. The long-term glucocorticoid more than 3 months. That's a NAMS recommendation. Research, more recent research has also shown that even dose pack prednisone increases fracture risk. Even inhaled long-term corticosteroids can increase fracture risk. Like all medications, the higher the dose, the longer duration, the bigger the risk. But even, at least with the long-term prednisone, when they come off of it, we don't know yet if they actually regain their pre-medicated level of bone strength. But the fracture risk does go down over time when they discontinue that. I mentioned that before. The pooled risk for subsequent fracture within 5 years, if you've had one, is about 30%. Little variability with age. It doesn't matter if they're younger or if they're older. 5-year risk for fracture, though, when they actually got to that 75 to 84 years old range, it gets up to 42%. But interestingly enough, it goes down when they're over 85. My assumption is it's probably because they're maybe less mobile. They're not moving around as much, but I don't know why that was the case. I was talking about medication-induced osteoporosis because this is an area where we as naturopathic doctors can really shine. This is a huge blind spot for conventional medicine right now. Sure, they know about prednisone. They know about aromatase inhibitors. But what is being missed are the SSRIs, the SNRIs, and the acid-blocking medications. A study came out, and I think I'll review it here in a minute, so I won't go into the details now. But for people over 60 years old, 85% use at least one prescription medication. Knowing that this is, doing an intake and having bone health when you're looking at their medications on your mind is important. So this is the study. They looked at medication use in the months prior to fracture, and then what medications they were on after they were hospitalized, after the fracture. And basically what the data showed is that many people were on medications that either increased their risk for falls, that decreased bone density, or increased their fracture risk. In fact, 76% took one or more medications that increased their fracture risk. I quoted this in my slide because I thought this is really, this is the bottom line. Yes, they took the patients off some of the medications like prednisone or switched a medication. They identified the medication as something that could cause fractures and osteoporosis, and they switched them to a new medication. But oftentimes they just switched them to a different medication that caused osteoporosis and fractures. So overall, there was no net benefit at all in terms of reducing damage to bones and increased fracture risk. And there it is. You can see top one, sure, oral steroids, it's common. Okay, let's decrease that so that you can see the column on the right. The number of patients taking oral steroids decreased, but then people, the number of people on proton pump inhibitors increased. The number of people on SSRIs increased. The number of people on antipsychotics increased. So again, there was no net benefit. So let's look at SSRIs and SNRIs. 24% of women 60 years or older took antidepressants in 2018, or were taking them. Now, I assume that's higher now, given the pandemic, given the economy, given our incredibly toxic politics these days. I imagine that's higher. The SNRIs, though, when you look at those, it's some practitioners conventionally don't believe that those damage bone. I had to send studies to somebody's MD because they refused to believe it. And because the only thing that changed from I hadn't seen this woman since her previous DEXA scan, the only thing that changed is she started an SNRI. And she said, and then she went back and talked to her doctor and said, my doctor said it's not the drug, the SNRIs don't cause osteoporosis. So I had to send him studies, and finally he switched her medication. So for SSRIs, there's a 1.6 times, so 160% faster bone loss. Why is that? So most of estrogen is not in the brain, or most of serotonin, I'm sorry, is not in the brain. Most of the serotonin is did I say estrogen before? Sorry, everybody. Serotonin, SSR is serotonin in this section. So most of serotonin is not in the brain. It's actually in the periphery. It concentrates in platelets and is carried around the body. Osteoblasts and osteoclasts have serotonin receptors on them. And what happens is when serotonin increases in the bone, it increases the activity of osteoclasts. And so that's the mechanism by which these are artificially elevating serotonin and damaging bone. So what we know with SSRIs, for every 19 people who are on an SSRI now for 1 to 5 years, we anticipate that one person's going to break a bone. For every 85 people on SSRIs for 1 year or less, you should anticipate that one of them is going to break a bone. I keep hitting the laser thing. So this is another meta-analysis. This is the one about for every 19 users, expect one to break a bone. What about SNRIs? So this 10-year Canadian study actually found a 68% increased risk of fractures with either an SSRI or an SNRI. Here's the mechanism of action. Serotonin, 95% of it is in the periphery. And is there anything on here I missed before? They also, they decrease osteoblast proliferation. That's how they work. So acid blocking meds. 50% of PPIs were written for just acid reflux, which everybody in here knows can be effectively stopped and treated oftentimes with diet and lifestyle issues. But people who were on PPI, so PPIs increase fracture risk, right? Bottom line, it's here, it's in this talk, it's in this section, so it does that. But if you were prescribed a PPI specifically for acid reflux, there's a 349% increased risk of fractures beyond, even above the risk for fractures for people who are prescribed PPIs for other indications. PPIs were never approved by the FDA for long-term use. After 4 years, one study showed there's a 60% increased risk of hip fracture. It just kind of goes up as time goes on. A JAMA study in 2006, the odds ratio for fracture was 85% higher in people using PPI for more than 1 year. And for a hip fracture, 44%. So this, again, it's all sites, 85% increased risk. But when you're looking at just hip fracture, the most dangerous type of fracture, you're going to 44% increased risk. Also a 23% increased risk with histamine receptor antagonists for hip fractures. Like all medications, increased duration increases the risk. The risk was stronger in men than in women. Why, I'm not really sure. There was a 78% increased risk of hip fractures in men and a 36% in women. And this is the study when it was restricted to just patients with acid reflux, 349% increased risk of hip fractures. So again, not a good story when it comes to a medication that is now available over the counter and that is being prescribed long-term, just like candy. This issue of hip fracture or a fracture risk is not new, by the way. The first study came out, I believe it was 2006, and the FDA actually came out with a warning in 2010 about PPIs and fractures. So what do people, clinicians who prescribe osteoporosis medications, a standard of care, do when somebody has a medication-induced osteoporosis situation? They prescribe a drug. Which drug is typically prescribed? Usually it's still Fosamax, right? Oral bisphosphonate. It's the standard of care. The assumption is, hey, we use this medication for postmenopausal osteoporosis. It must work in these other situations as well. The problem is the mechanism of action of how bone gets destroyed in postmenopausal osteoporosis is not the same with how it gets destroyed with PPIs or other drugs. So somebody decided to look at this. They finally studied it, said, wait a minute, let's look, does giving a PPI with a medication actually work? What they found out is that those people who took an oral bisphosphonate who also were taking a PPI had a 52% increased risk in fracture compared to people who were only taking the bisphosphonate. Fucking ridiculous. I mean, it is. It's just stupid. All right, I'll get off my soapbox. Falls and fracture risk. It's not just fractures, it's falls. 95% of fractures occurs because somebody falls, so we want to try and prevent that. PPIs also reduce the risk or increase the risk for falling, and it increased the risk not just for falling, but falling that resulted in hospitalization, right? Anything else? The H2RAs didn't really seem to do that. So look, if somebody has to be on a PPI or an acid blocker, it appears, at least when it comes to bone health, an H2 receptor antagonist medication like Tagamet appears to be safer than a proton pump inhibitor. But there still is that bone issue happening. Oh, and here's a study about bisphosphonates and PPIs, so y'all can go read that. It'll put you to sleep at bedtime, I'm sure. And then again, the last bullet there, no published clinical trials with PPIs and other categories of osteoporosis medications. So there's a real lack of data with medications. So with glucocorticoid-induced osteoporosis that I'll speak about, there's more data. It's been around longer. It's a known issue. What works with it? What medications will reduce fractures? But with PPIs, not so much. So let's talk a bit about sleep. So not getting enough sleep is a risk for falling. Not getting enough sleep destroys bone. The optimal amount is about 7 to 8 hours a night. 30% of men get less than 6 hours, and 20% of adults sleep less than 6.5. So when you look at diseases with decreased melatonin, so this gets into a much more integrative and nuanced look at what's going on to try and help somebody. When you're looking at all these diseases here listed here, decrease melatonin. Beta blockers also decrease melatonin. So if somebody's on a beta blocker and they're coming into you and suddenly they're not sleeping well, give them a little melatonin. Recently, there's a clinical trial on melatonin in women, postmenopausal women with osteopenia, not osteoporosis. A dose response study, 1 milligram and 3 milligrams were used. Both, but there was a dose response. The 3 milligrams was better. Increased bone density over the time period. Unfortunately, they didn't look at fractures, but it is showing, obviously, that it has a beneficial effect on bone. Concomitantly, or the opposite of that, is that we do know that not getting enough sleep increases somebody's risk for osteoporosis and fractures. Light-emitting devices, I like this study because it showed that if somebody is reading on an e-reader before bed, they may have only about 10 minutes to take 10 minutes longer to fall asleep than people who were reading on good old-fashioned, paper. And I thought when I read this, well, that's not a big deal. And as clinicians, you may hear somebody say, well, I'm on my device at night, and no, I can fall asleep, no problem. Falling asleep wasn't the issue. It was that it took them hours longer the next day to feel fully awake. So which to me indicates, and to these authors as well, they're not getting into the deep stage 3 and 4 stages of restorative sleep, which is crucial, as we know, for total health and important for cellular and tissue repair. So it's important for bones in that sense. So these are all medications that cause sleep disturbances. There's quite a few of them. Beta blockers I mentioned. Treatment emergent insomnia. These are some, again, these are insomnia caused by different medications, antidepressant medications. So let's get in. I wanted to spend a little more time on the osteoporosis medications and a little bit more on medication-induced osteoporosis as well. So there's a long list. All of them, as I mentioned, will improve bone density. But let's look. This is maybe a little, I don't know if you can see it on there. So they looked at so here's the bottom line. It's about fractures, right? Do these medications reduce fractures? So first of all, the number needed to treat for vertebral and hip fractures over 3 years was calculated in this study from different clinical trials, right? And what they found that to prevent one hip fracture in somebody with osteoporosis, you'd need to treat 91 of them with Fosamax. And for a vertebral fracture, you need to treat 14. So again, it's showing that it's much more effective at vertebral fractures than hip fractures. But what is really interesting in here is, and think about what I said before, that these medications don't prevent primary fractures. The oral bisphosphonates do not prevent primary fractures. So when you start looking, it is so frickin' confusing when you start digging in the research, because they're not defining whether it's a primary or secondary fracture. They're not parsing out the data to that level of detail. And so you get these studies that are being used to create standards of care that are showing that, oh yes, if we treat 91 patients, we're going to prevent one hip fracture. But they don't say if it's primary or secondary prevention. And so there's a ton of confusion out there. There was a study in Europe actually that looked at why people are not getting treated well for osteoporosis and not getting screened enough for osteoporosis. And I believe it's the same situation here in the US. One is that there's a lot of confusion by doctors about what to do about osteoporosis when they see it. The second thing is that these conversations about sleep, about diet, about lifestyle that all of you can already do in your sleep. I'm sure I'm repeating some things about sleep that almost everybody knows in this room. Those conversations take time, and they're nuanced. And people in the conventional system don't have the time, if it's an insurance-based system in particular, don't have the time to address those issues. And they don't, and this is what the study showed, they don't, which we all knew already, they don't feel competent to be able to have those conversations about diet, about lifestyle, and then the treatment regimen around osteoporosis, beyond just monitoring bone density. So back to this slide. When you're looking at other medications too, the story is basically the same. Boniva actually has no benefit for hip fractures, right? When you're aggregating all the data, only vertebral fractures. For Prolia, you want to prevent one hip fracture, you've got to treat 200 people with Prolia, according to this study. You want to prevent a hip fracture with Avista, good luck, it doesn't do it, doesn't work. Conjugated estrogen, effects on vertebral, hip, or overall fracture rates are not known. Similarly with Forteo, you want to prevent a hip fracture, you got to treat 200 people, and vertebral fractures, 11 people over 19 months to prevent one fracture. So I'm going to talk a bit about the bisphosphonates. So this, what do I want to talk about on this? So I talked about this a bit. So this study did actually look, the bottom bullet point there, did look at primary versus secondary fractures. So they enrolled women who had never had a fracture, and what they discovered is that women 60 years and older, if they never had a previous fracture, that oral bisphosphonates have not been shown to better decrease risk of first fracture compared to calcium and vitamin D therapy alone. Now that's from this study. Now calcium and vitamin D has been shown in different studies to reduce fractures maybe 10 to 23%. So this was one study. In other studies that looked at it, they've said they don't reduce, the oral bisphosphonates don't reduce primary fractures at all. When a meta-analysis was done that looked at not just one study like this one, but looked at different studies that looked at this issue, that was their conclusion. So glucocorticoid-induced osteoporosis, several meta-analyses have been done. That basically with Fosamax, there were 9 randomized clinical trials. The American College of Rheumatology even says that because of limited evidence regarding the benefits and harms of interventions with glucocorticoid users, most recommendations in this guideline are conditional, uncertain balance between benefits and harms. I bet there's probably not one primary care physician out there who, or maybe there's one, it's a big country, who knows this. Right, who could tell you that the recommendation they're giving is not based on any clinical evidence to give a bisphosphonate for glucocorticoid-induced osteoporosis. No, not based on clinical trials. So the first meta-analysis, there were 3 cohorts evaluated in that study. The bisphosphonate, though, did reduce hip fractures. The risedronate did reduce hip fractures. Didronel did reduce vertebral fractures, but little evidence in reducing hip fractures. So oral bisphosphonates grouped together are associated with a reduction in hip fractures and vertebral fracture risk. But even the American College of Rheumatology says the guidelines are conditioned. There's an uncertain balance between benefits and harms. And yes, it may reduce these risks, but what are the harms caused by the bisphosphonates? What are the side effects caused by those medications? So there was a meta-analysis that looked at Prolia for glucocorticoid-induced osteoporosis, and it did appear that lumbar bone mineral density was increased, femoral neck bone density was increased compared to the bisphosphonates. So they did a drug-to-drug comparison. But they're underpowered to detect the risk of fractures. So still hadn't looked at that as of this 2019 study. No meta-analysis with Forteo. Clinical trials show it may be more effective than alendronate for fractures, but no clinical trials yet. So let's talk about treating PPI-induced osteoporosis. So I talked about this study before. There are no other medications and osteoporosis medications. None of the other ones have been studied with PPIs in clinical trials. So, it's basically rolling the dice. If somebody has a PPI-induced osteoporosis and or an acid-blocking induced osteoporosis and they end up getting a medication, is it helping them? Is it hurting them? We now know that bisphosphonates actually increase their risk for fractures. But what happens in the real world? Let's say somebody does want a medication is indicated, there was ample discussion with the patient so that really true informed consent can be given. And what I find is that most of the time patients don't understand enough to really give informed consent, because just one simple question that isn't being asked and answered is, does this reduce my risk of fractures given my diagnosis and my medical history? I've never had a previous fracture, and my osteoporosis is caused by my acid-blocking medication, or I have postmenopausal osteoporosis. So one of the things I'm passionate about and that I do in my book, in the chapter of osteoporosis, I give patients questions to write down and ask of their doctors when they go in, so they can really understand not just the treatment now, but what are your plans for me? How long will I be on this medication? And wait, you're saying I need to do medication X for 4 years, 4 years, and you're going to take me off of it? Well, what's your plan after that? What do I do after that? Are they just going to switch them to another medication? Right, so getting that whole complete picture, I think, is important for patients to understand. But let's say they get the medication. 70 to 80% of prescriptions for osteoporosis medications have to be taken in order for you to get the real world effect, in order for you to get the benefit, the reduction in fractures, the increase in bone density. And I say that both of those in this terms because that's really what they're looking at the research, right? They're looking at increase in bone density, they're looking at that benefit, they're looking at fractures, right? But about half of people who are prescribed oral bisphosphonates, they stop within a year. So when you look at both vertebral and non-vertebral fracture prevention, there's the summary of what I've been saying a couple times. So you can look at, I create a summary table. I like summary tables. They're very handy and helpful. So hopefully this can help you. So let's talk about stress a little bit. So everybody knows that Cushing's disease, I hope everybody knows, right? Anybody not? Well, you probably wouldn't raise your hand. But everybody knows that Cushing's disease can cause osteoporosis, right? So you end up with pathologically high levels of cortisol, which is similar to taking a glucocorticoid. But actually what this one study found is that even in the healthy range, the normal healthy patients that were studied, they had a faster rate of bone loss, right? So whose cortisol was in the normal range but was towards the high end of normal. So the chronic stress, living a chronically stressful life, damages bones. In women, elevated peak plasma cortisol was associated with a lower baseline bone mineral density at the femoral neck and greater rate of bone loss at the femoral neck as well, 24% faster bone loss. So let's talk briefly about, how much time do I have left? Perfect. Social support. Why am I talking about social support in a talk about osteoporosis? Well, what the research has shown is that it plays a vital role in many areas of aspects of our health, but it also has been shown to people with a strong social support network, with 3 people within that network, not 4 or 5, with 3, it was associated with lower risk of osteoporosis. All-cause mortality, that includes dying from a hip fracture, is 30% lower compared to people who are more isolated. So people with a more highest social interaction skill had a 30% lower all-cause mortality risk. So it's not just that you have to have, a good social support network and, 3 people or more in your life, but you've got to interact with them. You've got to do things. The more people were social, the more they went out, which is one of the reasons why the pandemic and all the isolation has been so damaging, I think, to people's health. Poor social support is also associated with faster bone mineral density loss and worse recovery from a hip fracture. Mediterranean diet is my favorite dietary pattern. You can talk keto, you can talk alkaline acid. Those to me are great, but I'm going to say show me the data. Show me the epidemiological evidence, show me the studies, the prospective studies, show me the data. Consistently over 30, 40, 60 years, the Mediterranean diet, I don't know of one negative study that's ever been published on the Mediterranean diet. When it comes to reducing cardiovascular disease risk, diabetes disease risk, cancer risk, death from cancer, all-cause mortality, obesity, on and on and on. And now we find out that the higher adherence to the Mediterranean diet also is associated with lower fracture risk as well. So this was, there are limitations, obviously, with food frequency questionnaires, but that's what was, and they addressed some of those limitations in this study. But what seemed to be protective were legumes and red wine, and also fish and olive oil. Probably none of that's probably surprising to this group. And this also confirms earlier studies about the bone benefits of that dietary pattern, which is essentially a plant-forward, whole foods diet, which has lots of good, healthy, lean protein in it. A meta-analysis, a higher association in the Mediterranean diet was associated with a 21% decreased hip fracture risk and higher bone mineral density. And it was also it was associated with healthier lifestyle. So not surprising either. In one domain, if people are being healthy in one domain of their life, whether it's diet, they are likely to be healthier in other domains like exercise and sleep, and maybe even getting toxic people out of their life, which is a good prescription. I like prescribing that to people. Other studies report 6% fewer hip fractures as well. So what about vegans and vegetarians? Consistently, the research has shown that they have lower bone mineral density and are higher risk for osteoporosis. Now, there are some studies out there that do show that that's not the case. And the authors of this review article that I was looking through and reading speculated that it's likely because the amount of protein, it may come down to the amount of protein, because eating a whole foods diet, eating lots of green leafy vegetables is associated with bone health, is associated with a lower risk for osteoporosis. Right? So why in this group of people that are obviously eating a lot of plants is their risk going up? Well, it's probably because they're not getting enough protein. So let's talk about protein. Most people I find are not eating enough protein despite the high protein craze and how popular it is. I like to do a 24-hour diet recall because people seem to eat the same stuff day after day, and then I'll have them track their diet once I get buy-in and they're actually involved in their own health. I'll have them track and write down for 2 days what they've eaten and calculate how many grams of protein and how many grams of fiber they're eating. That's all I have them look at is protein and fiber. What I find consistently is people aren't eating enough protein. And even the US RDA for protein is insufficient for maintaining muscle mass as people get older and for reducing the risk for falls and fractures. So 38% of adult men and 41% of adult women eat less than the RDA for protein, and 15% of older than 60 years old consume less than the RDA. 15% of people older than 60 years consume less than 75% of the RDA, I should say. That's a lot of percentages in one sentence. Everybody follow that? 75% of people over 60, 15% of people over 60 only consume 75% of the RDA. Got it? Bottom line, not enough protein. I should really rewrite that slide. Sorry about that. So, people on average lose about 3 to 5% of their muscle mass as they age, and by the time they're 80, they're going to have about 15 to 25% less skeletal muscle. So how much protein do you need? Well, you need more than the US RDA. The research shows that clinical trials have looked at 1.2, 1.3, I believe 1.5 grams per kilogram body weight per day, and some recommendations go up to 2 grams per kilogram body weight per day to maintain and actually increase muscle mass combined with resistance exercise. So this study I thought was really clever. It was just over 4 weeks. They had a controlled diet of 0.8 grams of protein per kilogram body weight per day, which is within the RDA, right? It's a lower limit, but it's right there. And what they showed is that even just in that time period, the mid-thigh muscle area decreased by about 2 centimeters, right? A mean of about 2 centimeters, and just in that amount of time, all right? So here are the recommendations. So let's talk about walking. So I'm also a fan of not, meeting people where they're at and not telling them they've got to go and completely revamp their life, and not telling them they've got to become a gym rat. Because a lot of people don't like to work out in a gym. I don't like working out in a gym. And even simple things just as walking, helpful. But oftentimes things that are the gospel in medicine or health, and you see out there in the internet, the 10,000 steps, you got to walk 10,000 steps. When I looked for data on that years ago, it didn't exist. Well, now fortunately, there are at least 3 studies that have looked at this. How much do you have to walk? How many steps do you have to take a day on average to get the health benefits? Well, actually, it plateaued at 7,500 steps a day. So between 7,000 to 7,000 steps a day, there's about a 30% reduction in all-cause mortality, which includes dying from a hip fracture. So we know that in general, moderate to physical activity is associated with a decrease in hip fracture risk by 45%. So using the talk test, I like that as a good, if you can have a conversation but you're winded, that's moderate physical activity. There are really no, did I include this? I did not. Sorry about that. So I did not, I say picture 1, picture 2, picture 3, 4. It's in my book, the pictures. But 20 minutes. 20 minutes until questions or 20 minutes until questions? Okay, great. So there's a lack of clinical trials when it comes to exercise and fractures. You would need about 7,000 patients in a prospective clinical trial to evaluate them for fractures. And so there have been a lot of recommendations for different types of exercise, and people are sent out in the world with, oh, just go exercise, go do yoga, go do Pilates. Well, the problem with that is, as I've gotten to know and speak with people who are much more knowledgeable about exercise in the osteoporosis patient population and work with them, that actually can increase their risk of fractures. So if someone's got severe osteoporosis and they go into a pigeon pose, that stress on the pelvis can break their hip. And similar with Pilates, if it's not modified, if it's not done correctly, it can put some stresses on the bone that can result in injury. So it's important in your community to network with people, find people who if you have them, who have actually knowledgeable and work in the field of exercise with can work with your patients who understand how to do so safely with osteoporosis. But this study actually was the first study that I could find that looked at not the ability to reduce fractures, but the risk of fractures with exercise. And it was in 1984. And they gave them 4 different exercises. So one was sitting in a chair with a back, the one was back extension while laying down. So laying down, like that Superman, is that Superman pose like this, right? Kind of arching your back while laying down. I'd lay down, but I don't think they could see me up there. The extension in a seated position, so sitting in a chair and extending back like that as well. Stretching by bending forward, so again, sitting in a chair and just bending forward. And sit-ups. And what they found is that, and how long was the study? This was 1.5 to 2 years. 16% of women doing the extension exercises had new spinal fractures, while 89% of those doing flexion exercises and 53% of those doing a combination of flexion and extension had new spinal fractures. Don't do that. Modify it, right? It's kind of like the story with medications. Understand the risk and the benefits. And is there a safe way to do it? This shocked me because I assume that sit-ups and bending over and stretching, and that's what a lot of kind of yoga is, and other types of exercise is healthy. It wasn't really on my radar as much to do back extensions. I'm doing them a lot more now because they seem safer. I don't have osteoporosis, full disclosure, but I am 52. And how I exercised in my 20s is not how I can exercise. No, I'm not. I'm 55. Holy shit. I'm 55. That just happened fast. How I exercised in my 20s and how a patient in their 60s should exercise is not how they should have been exercising decades earlier. As I mentioned, lack of direct evidence from randomized controlled trials about fracture reduction. Results from a meta-analysis showed about an association of fracture reduction of about 45% with hip fractures among men and women, 45% among men and 38% reduction among women just with exercising. Moderate to vigorous exercise. A meta-analysis of fall risk showed Qigong or Tai Chi decrease falls and fall-related injuries by 75%. So anything that you could do to increase balance, not just focusing on bone, the tissue, but focusing on balance as well is important. I love the stork exercise. Does anybody not know what the stork exercise is in here? Well, I did get a hand raise. So the stork exercise you do while you're brushing your teeth. And everybody hopefully is brushing their teeth twice a day. If you're not, please take a mint before you come and talk to me. And for 2 minutes each time. So while you're brushing the bottom teeth, storks like to stand on one leg. You stand on one leg and you brush your bottom teeth. And hopefully you might have a timer, on your toothbrush. It's a digital one. And so it's going for a minute, and then when it beeps, you switch to the other leg, right? And you do the top teeth. If they need to steady themselves somewhere, they can do that, right? While they're balancing, while they're brushing their teeth, and over time, hopefully be able to let go. So that alone, get a little bit of core muscle, a little bit of adductor muscle involvement as well, quadriceps involvement, strengthen the muscles, you get glute involvement, stabilize the core to help reduce the risk for fractures. And what then they can do once that becomes easier, they can switch hands, try and do it brushing their teeth with their non-dominant hand, right? And if it can help, it might help them too if you recommend they if they can visualize the core, not ceiling, the floor, pushing up, through their foot, through the base of their foot, kind of help them to stand taller and give them a mental image of strength may help as well. So I like that exercise. Simple. I like simple. I like this European recommendation for exercise and diet because it actually recommends protein as well as physical activity. So taking physical activity 3 to 5 times a week combined with protein intake in close proximity, and they're recommending dietary protein intake of at least 20 to 25 grams at each meal of high quality protein. At least, that's a minimum. In the US, I've yet to find any recommendation that combine exercise and diet, as well as take calcium and vitamin D. All right, so let's look at nutrients. Everybody in here, I'm sure, does nutritional medicine. I'm sure prescribes nutrients. What's the most important question? Somebody shout it out. Does it reduce fractures? Have the nutrients been shown in clinical trials to reduce fractures, right? There are only 4 nutrients that have been shown in clinical trials, prospective clinical trials, to reduce fractures as the primary endpoint in the studies. Calcium and vitamin D, MK4, a specific form of vitamin K2, and strontium. There's intriguing research on melatonin. There's actually, it didn't make the slide, but there's also intriguing research on collagen, supplementing with collagen as well, that if I have time, I'll mention it. So let's look at vitamin D and calcium. Vitamin D alone has not been shown to reduce fractures. It has been shown to reduce falls, but there's some caveats on the next slide. I mentioned before, calcium and vitamin D have been shown to reduce fractures by about 10 to 23%. Most of the studies use calcium carbonate. Other forms, as you all know, is more absorbable. Calcium citrate specifically is 24% better absorbed than calcium. And in the presence of low stomach acid, that absorption, increased absorption over calcium carbonate goes up because calcium carbonate needs an acidic pH. Calcium citrate needs a more basic pH. So let's look at vitamin D. Hopefully everybody's testing vitamin D levels. So the sweet spot for fracture reduction in vitamin D and for fall reduction is about 30 to 44 nanograms per milliliter, right? For immune system benefits, it looks like that's higher. I've seen recommendations 50 and 60 nanograms per milliliter. I just did an abstract and commentary review on vitamin D in COVID patients for the Natural Medicine Journal. I don't know when it'll be coming out. I just submitted it before I got on the plane. But and in that study, in studies, it looks like that threshold for COVID for immune system benefits, not just surrogate markers like looking at interleukins and inflammatory markers like CRP, but looking at hospital stays, ICU admissions, it looks like that threshold is about 50 nanograms per milliliter. But the dose
and the actual serum concentration, I've got a little bit on a tangent right now, but the actual serum concentration is not well defined, and whether D2 and D3 is better for COVID, that's not yet really well defined either. Okay, back to this. 30 to 40 nanograms per milliliter seems to be the best fracture reduction, the best fall risk reduction. So when you look at the hip fractures, you're talking about an 18% reduction in hip fractures when they pooled the data, and that's a relative risk. So the second bullet point, the big one, second of the big bullet points, this I really want to drive home this idea because it relates to what I said before about bone density tests. Higher bone density is found when you get to 9 to 37.6 nanograms per milliliter, right? But you don't get the fracture reduction until you're up at above 30. Right? So someone's looking at their bone density and saying, okay, you're taking 800 IUs, and yeah, you're about you're 20 nanograms per milliliter, 25 nanograms per milliliter. You're doing great. Don't make any changes. Well, the actual optimal reduction in hip fractures is at a higher threshold, 30 to 44. So they need more vitamin D. For fall prevention, what's interesting is it actually does correspond well to the fracture prevention as well at that 30 to 44 nanograms per milliliter as well. People taking less than 700 IUs a day did not have a reduction in falls. And people below 24 nanograms per milliliter also did not have a reduction in falls. So you want to get it up to 30. Despite all of this data, the U.S. Preventative Services Task Force recommends against routine supplementation of vitamin D to prevent falls in the elderly. So a little more lunacy out there, but there it is. Calcium safety. This is an issue. I'm sure people have heard of this issue. There's some calcium safety challenges that are going on that have come up. Is it safe? Is it not safe? What the consensus seems to be at the moment is that if you take less than 1,000 milligrams a day, you're safe. And the challenge may be actually not supplementing with calcium, is that people are supplementing with way too much calcium. I'm seeing recommendations, people coming into me from other providers where they're taking 1,200, 1,400, 1,600 milligrams of calcium, way too high, ridiculously high. A position statement from the National Osteoporosis Foundation and the American Society for Preventive Cardiology is that, well, we all know, first of all, supplements should be a supplement to diet. So hopefully you're taking diet into consideration as well whenever you're talking, especially about calcium. The tolerable upper level of intake for calcium is 2,000 to 2,500 milligrams per day. So you want to supplement according to that. You don't want them to get too high, and then it can become dangerous. The average American woman gets 800 milligrams per day of calcium in their diet. All right, so if you supplement them with an additional 400 milligrams of calcium, hopefully your patients are eating better than that. They're going to be getting within that healthy range, and there's still a huge, ceiling, a lot of space to go before they'll be pushing up against getting too much anyway, for it to be possibly not safe. So let's talk about vitamin K. All forms inhibit osteoclast activation. All forms will improve undercarboxylated osteocalcin and have a positive effect on bone mineral density. The two forms you find in dietary supplements are MK4 and MK7. Only MK4 has actually been approved by the Ministry of Health in Japan since 1995 for the treatment of osteoporosis and bone pain caused by osteoporosis. Again, back to the bone density story. 2011 guidelines out of Japan state that minotetrinone, which is MK4, is considered to exert its fracture-reducing effect via a mechanism of action other than increasing bone mineral density. MK4 is the only form of vitamin K that has also been shown to have anti-neoplastic activity. I've received multiple US FDA orphan drug designations for the potential treatment of MK4 for acute myeloid leukemia, myeloid dysplastic syndrome, promyelocytic leukemia, and hepatocellular carcinoma, based on data from published clinical trials that we submitted to them for evaluation. And they concluded, yes, based on these studies, it has the potential to treat these rare diseases. We will award you orphan drug status. They are not treatments. None of these are treatments. These are dietary supplements. They're not approved by the US FDA to diagnose, prevent, or cure any disease. They promote health. Enough said about that. All right, so look, vitamin K2 is a category of molecules, right? So MK4, MK7, there are other menaquinones. They're designated by numbers. They're not the same molecule. As we all know from biochemistry, if you change one side group or one carbon atom, it can have different effects. It does have different effects. Like a Venn diagram, there's a lot of overlap, right? But not complete overlap. That's why they're not called the same things. They're not the same moiety. So here are the clinical trials in MK4. Bottom line, there are over 7,000 volunteers in about 28 clinical trials with MK4. 7 of those have looked at fractures. These have all looked at different postmenopausal osteoporosis patients, medication-induced osteoporosis patients, disuse from stroke, immobilization, anorexia nervosa. Most of the clinical trials reported bone density, but 7 of them reported fractures. So the 2 meta-analyses have been done on this data. This one, is this the 2006 one? No, this is 2019. So 2019 one, this is a different one. So, this is really interesting. Just like with the bisphosphonates, there's a huge problem out there in the vitamin K research. These researchers are just saying vitamin K or vitamin K2, and they're lumping it all together and not saying which form of vitamin K was used. I've had to actually email researchers of articles, even clinical trials, say, which form did you use? So this it lumped them all together, and it said, well, vitamin K doesn't work, right? They were looking at fracture risk. It doesn't work on fractures. Yes, it can improve bone density, but they lumped them all together. And they even said in their conclusion, quote, our results cannot be confirmatory with regard to the relative effectiveness of different vitamin K regimes. And my concern is people see this and they don't read it close enough, and they just read the abstract and like, oh, well, all right, it doesn't work. So dietary vitamin K, there's an inverse association between phyloquinone intake and fractures. About a 28% reduction with the highest quintile. For each increase of 50 micrograms per day, there's a 3% decrease in relative risk. 2006 meta-analysis. So 2 articles were retracted after 2 clinical trials were retracted after this meta-analysis was published. Fortunately for us, they did an analysis of the subset of the data already within the published study. They had already done it. They had already taken that data out in a table, in a separate evaluation, and looked at all of the data without those studies included. Actually, they had removed 3 studies, right? Even without those, excluding those studies, there's still a 60% reduced risk in vertebral fracture and a 76% reduced risk in non-vertebral fracture. A 2015 meta-analysis, when they removed studies for heterogeneity, found a 53% reduction in fractures using MK4. The dose in the clinical trials is 45 milligrams per day. Be clear of that. No other dose, lower dose, has been shown to work. Clinical trials in cancer have gone up to 135 milligrams a day, just so everybody's aware of that. All right, and these were done, this is specifically postmenopausal with women with osteoporosis. There's a clinical trial on glucocorticoid-induced osteoporosis with 45 milligrams per day of menaquinone, showing that it increased the bone density. It stopped and reversed the bone loss. Those other studies too, and other like Leuprolide, same thing. Fracture was not an endpoint, but we do know that it reduces fractures. Safety, it's safe. With all these clinical trials, animal, human studies, no danger, no risk of any pathological blood clotting. Once there's enough blood clotting in the body, the vitamin K goes on and does other things. The MK4 goes on and does other things. By the way, MK4 is the predominant form of vitamin K that accumulates in tissues throughout the body: breast, pancreas, intestines, brain, indicating, and testes, so indicating that it likely has other beneficial effects beyond bone as well. And our body does have the enzyme that can convert phyloquinone to menaquinone. It's the only form of vitamin K that's actually produced by our own biochemistry. Let's talk about strontium. How many minutes do I have before questions? Quick, right? 5 minutes, perfect. Strontium is very popular. Strontium ranelate is approved as a medication in Europe and some European countries for osteoporosis. We don't have strontium ranelate in the US, but because it's been approved as a medication, it's been really well studied. In the US, you'll see products with strontium, typically strontium citrate in their products. Strontium does improve bone density. Strontium does reduce fractures. But there are a couple caveats that it's important to be aware of when it comes to strontium. The first, and I've got all the studies in here, is that, here's 3 of them. I think there's 6 in here. The vast majority of the studies have only shown vertebral fracture reduction, not hip fracture reduction. The second thing to be aware of is that strontium incorporates into bone, and it's a mineral. It's heavier than calcium. A bone mineral density test is an X-ray. It's a radiological exam. It goes into the bone and it bounces off the minerals. The angle that it bounces off the minerals is detected by the machinery. It goes in there, it does its mathematical magic and spits out a number, right? That angle is called the refractive index. Because strontium is a mineral and it's heavier than calcium, the magic X-ray comes in, the beam comes in, hits the strontium, and it bounces off at a different angle. Our machines in the US, because it's not approved as a medication, cannot correct for that. So the bone density test results are wrong. They're false, or potentially false. Despite the limitation of the bone density tests, I believe patients should get them as screening. They should get them regularly for monitoring, and they should be accurate. We want them to be accurate. The second thing, this is just all the clinical trials if you want to go through them. Oh, I guess I didn't do a safety slide. The second thing, did I do a safety slide on this? Let's see, where's the safety? Oh, all right, this is not on there, so that you get this is a bonus material. The second thing, the other thing with strontium is that a review of European regulatory data and published studies have shown that strontium ranelate, because that's the only data we have, there are no clinical trials on strontium citrate in fractures or bone density that I'm aware. I mean, I looked recently, I didn't find them. There are no, the strontium ranelate data show that it increases the risk for venous thrombosis, pulmonary emboli, and stroke and heart attack. So the conclusions of the studies of that, and it's in my book and the citations are in the book, you can look that up. The conclusion is that for every 1 patient that we're going to reduce fractures with, get 1 benefit with strontium, as strontium ranelate, we're going to cause 1 patient to have one of these blood clots and an MI or a stroke. So for those reasons, not a fan. Let's look quickly at melatonin, because I like this exciting new research. There are actually melatonin receptors in bone, and this is the randomized clinical trial I was talking about, 81 postmenopausal women with osteopenia, not osteoporosis, 1 in 3 milligrams of melatonin a day. It showed a significant increase, 3.6% with bone density at 3.6 milligrams per day. And this was bone density at the femoral neck, but not at other sites. So I don't know why it was only the femoral neck that increased and not other sites. And this is the first study to come out. So hopefully other researchers will take this challenge on and study this more in the future and actually look at fractures as well. All right, this is the end, but it's not the end, because I want to talk quickly about collagen. So some research came out a while ago, a clinical trial using collagen and for bone health and osteoporosis. And CTX, cetylopeptide, is a marker that's used that measures the collagen breakdown, specifically in bone. And elevated CTX, especially when it's combined with a low bone mineral density, is a good predictor is strongly associated with fracture risk. And there are medical organizations that do recommend CTX gets tested, and also is good for monitoring treatment as well, because you can run a CTX test more frequently than you can a bone density test. The other thing also that's a good laboratory test to look at is the neutrophil to lymphocyte ratio. That's been associated with osteoporosis and osteopenia, and you can run that more frequently as well. I'm not a big fan of tons of tests for osteoporosis. There aren't just very good ones out there. But sometimes people like to have data and see if they're on the right track, aside from us just telling them they're on the right track. So collagen, they gave collagen. CTX significantly decreased in people supplementing with collagen. So showing that it's having some benefits on bone health. Whether it translates to benefits on bone mineral density or fractures is still to be determined, but there was a review study that came out a few years ago of 60 different studies, article that came out, and the conclusion was that collagen has been shown to improve or promote health of skin, bones, joints, on and on. So collagen's everywhere in our body. So it seems to be helpful for bones as well. It is question and answer time now, and somebody was raising their hand. 2 people. Oh my God.
If you have a question, raise your hand and wait for the mic, because we need online people to hear you. Thanks. Did they distinguish in the studies between the type of collagen, type 1, 2, 3? You have any information on that?
Oh, I don't remember. I'd have to look. If you grab my cards over there and just email me that, I will send you the PDF. I'd be happy to. I don't remember what type. I can tell you. So here's the landscape of the collagen world, right? There are different types, right? So there's typically, when you're looking at bone, they're going to be used a bovine-derived collagen typically. In the studies. If they're looking at joints, they're more often using type 2 collagen in clinical trials. And then you have companies that are producing collagen raw materials that are highly processing their collagen. And so it may be derived from something. How well does it compare to a raw bovine, hydrolyzed collagen or not? I'm not sure.
Hi. I was just wondering what you're looking for in the neutrophil lymphocyte ratio.
So above 3.17 is associated with osteopenia, and above 4.68 is associated with osteoporosis. Above 3.17 is I believe it's 3.17. I may have the last 2 numbers reversed, but above 3.17 is associated with the osteopenia. Above 4.68 is associated with osteoporosis.
Hello. When you were talking about the bone density studies and how you can't really trust that they represent fracture risk, I've seen people with like a minus 2.5 fracture their hips, and then people with minus 4.5 never fracture a thing. Should we just look at more factors like you talked about today, or how can that?
So I want to be clear that I did not miscommunicate my belief in bone density tests. They do have clinical utility, and they can predict fractures, but they only predict 44% of women who will fracture and 21% of men overall. So it's not something to just completely discount, but like the North American Menopause Society and others have concluded correctly, fracture risk depends on factors largely other than bone density. It's one thing to talk about. It's one thing to maybe get more aggressive with, specifically trying to treat that number if it continues to go down, or I've had patients that are so anxious about it, they want that number to go up, so then I'll specifically start treating for that number, as well as doing other things to reduce their fracture risk beyond that. But typically, if they're at a negative 2.6, negative 2.7, I'm really not that concerned.
And
right?
When do you use Lendronate?
When do I use it? I never use it, personally. Yeah, not a fan. But a person, someone who wants to use it, would use it best used probably for secondary fracture prevention.
Okay. Hi. Hello, doctor. Thank you so much for all that information. I just had 3 follow-up questions. Hopefully they help answer other people's questions. One of them was, you mentioned an increased risk of bone loss with SSRIs. Is that the case with 5-HTP as well? Question number 1. Question number 2, difference between e-readers, I'm thinking of like the Paperwhite type low light versus like reading on your phone or other tablet and affecting sleep. And third question is, you didn't mention, or at least I didn't hear you mention the NTX test. I'm not familiar with the CTX test, but wondered your thoughts on that. Thank you.
So the answers to your first 2 questions are very quick and easy. I don't know, and I don't know. I don't know. And the research has never been done with 5-HTP to know that. I have a really hard time, though, thinking that you're going to get such a high dose of 5-HTP that it's going to cause an issue. Plus, you know, the rate-limiting step is between tryptophan and its next step, right? So if you're concerned, just give L-tryptophan instead. NTX. The reason why so studies looked at NTX and CTX. The one, if you look at the Natural Medicine Journal article I mentioned on osteoporosis testing, specifically I look at NTX and CTX in that article. And NTX was not a good predictor. That's why and it's not recommended by any medical organization that I'm aware of. But am I wrong about that? Anybody know that? But CTX is. So.
We'll take just one more question from the folks online.
Oh, one more thing about CTX. I mentioned low bone mineral density. Also, that increased the power of CTX to predict fractures is low estrogen. So I love the study that I review in the article because it actually looked at multiple variables. It just didn't look at CTX and fractures and NTX and fractures. It looked at both NTX and CTX, urinary and serum, and it looked at combined low bone mineral density and estrogen. So it's a great study.
Okay, so we have one question from online. Are you concerned about patients using strontium citrate, or is it just the ranelate?
The answer is the data doesn't exist. Safety data does not exist on strontium citrate. All we know is strontium ranelate. Strontium citrate may very well be completely safe. I don't know. All I can tell you is the only form of strontium we have data on, both clinical trials and safety data, is strontium ranelate. Time's up? Oh.
That's all the time we have.
Okay, a couple more questions now? No. I'll be over there. So my books are over there if anybody wants to talk about them, or even better, buy them. And a percentage of the proceeds goes to your association, and I'm happy to talk to anybody about this for the next 2 days while I'm here. I love this topic. I'm very passionate about this. And afterwards, you can grab my card and connect. So thank you. Thank you.